Get started here. So I haven't given this talk in a couple of years. I'm not sure how much this might show up on your core exam, but it definitely, we do get, this will infrequently come through the ER at night. And so I kind of wanted you guys to at least sort of have a clue. I've tried to simplify this as much as possible. I did not include, I have very little information about ectopic stuff. I know Dr. Chada did electron ectopic stuff, and so I'll save that for her for the most part. This is not an exhaustive lecture, but I'm hoping to hit some of the high points. And so hopefully you guys will get some good information out of it. So, special thanks, Dr. Woodward. She's the chief of GU Radiology at the FIP, or at least when I was a resident. And so she actually, some of the stuff in this lecture was due to her. She was a phenomenal lecturer, and actually after her lecture, it actually made a whole lot more sense. And so anyway, I wanted to give some thanks to her. All right, so our objectives for this afternoon, so at the conclusion of this talk, hopefully you guys will be able to interpret normal ultrasound findings and measurements in the first trimester OB ultrasound. Differentiate between different types of multiple gestations during the first trimester, and then recognize some of the fetal complications that can occur during the first trimester of pregnancy. So we've got a little pop quiz we'll start here with. I'll go over the answers here at the end, so if you want to just kind of be on the lookout for these things during the talk. So, normal or abnormal, what is that structure? Case 2, what structure is the white arrow pointing to? And what structure is the black arrow pointing to? You can't see the black arrow, it's right here. So, what is the chorionicity and amnionicity of these twins? And what sonographic sign is that? In our last case, what is the diagnosis in this 13-week fetus? And what structure is the straight white arrow pointing to? All right, so estimated date of confinement. Basically, it's determined from the first day of the patient's last menstrual period. And so you guys on ultrasound always harp on, okay, when was the last menstrual period? When was the last menstrual period? And so anytime you do a pelvic ultrasound in a patient who is of childbearing age, always find out when their last menstrual period was. Really any of them, but especially in these cases. So the first trimester is basically anything before 14 weeks. The second trimester is between 14 and 28 weeks. And the third trimester is after 28 weeks. So the date by LMP, so basically the ovarian period is the first 2 weeks. Basically the ovarian follicle matures, ovulation occurs, and then we get formation of the corpus luteum. The conceptus period is between weeks 3 and 5. Basically, that's when fertilization occurs. You get formation of the morula, the blastocyst, which is what actually excavates and implants into the wall of the endometrium, and then the so-called trilaminar embryo. The embryonic period is week 6 to 10. Basically, you get a C-shaped embryo. This is when the major organs develop, and then the yolk sac detaches. And then the fetal period is weeks 11 to 14. This is where you have significant fetal growth. The amniotic and chorionic membranes approach each other, and then the membranes fuse about 14 to 15 weeks. So beta, there's a close relationship between ultrasound findings and the quantitative serum beta HCG levels. Normally exists during early pregnancy, and so that's why the numbers actually mean something. So mean MSD is mean sac diameter, and beta HCG levels increase proportionately until about 8 weeks, at which time the mean sac diameter is about 25 millimeters, and you should actually see an embryo within the gestational sac at that time via transabdominal or endovaginal ultrasound. After 8 weeks, the beta HCG levels plateau and then subsequently decline while the gestational sac continues to grow. And a normal gestational sac grows about 1.1 millimeters a day, while the beta levels double every 2 to 3 days. So some important levels to remember. Beta around greater than 2,000, you should be able to see a gestational sac via endovag, or if you can't do an endovaginal study, you should see one by about 3,600 on a transabdominal study. So some new data shows that viable pregnancies can occur with a beta greater than 2,000, and there's no identifiable sac on endovag, and that's about around 2% with a beta between 2 and 3,000, but it's less than 0.5% if it's greater than 4,000. So if you have a patient in the ER comes in, beta's like 2,000, you don't see anything, just have them come back in a couple of days and rescan. Beta of 7,200, you should be able to see a yolk sac within via endovaginal ultrasound. And then once the beta hits about 10,000, you should be able to see the embryo via endovaginal ultrasound. Take-home point, in a woman with a pregnancy of unknown location, i.e. you don't see a gestational sac via endovag, whose beta is around 2,000, the most likely diagnosis is a non-viable pregnancy. Non-viable intrauterine pregnancy occurring about twice as often as an ectopic. But still, you're going to have to rule out an ectopic, but kind of keep that in mind. So, some early milestones in pregnancy. There's something called the intra-decidual sac sign that happens about 4 to 4.5 weeks. There's the double, and I'll show you some examples of each one of these. The double decidual sac sign. The yolk sac, which you typically see between 5 to 5.5 weeks. The double bleb sign, which is basically the yolk sac and the amniotic sac. Embryo forms within the amnion, and then the embryo with a fetal heart, you should be able to see heart tones at approximately 6 to 6.5 weeks. You must determine chorionicity and amnionicity in multiple gestation pregnancies. And basically the number of yolk sacs you see equals the number of amnions. So that gives you information there. So the intra-decidual sac sign, basically this is the earliest sign of intrauterine pregnancy seen, again, by 4 to 4.5 weeks after the last menstrual period, and you see this on endovaginal ultrasound. Basically, what happens is the fertilized ovum implants into decidualized endometrium, and so basically that's the endometrium reacting to the hormones of pregnancy, and basically the gestational sac will then burrow into the endometrium. And so what we're looking for in ultrasound is an echogenic ring, and it's just going to have an eccentric location. Again, it's burrowing into one side of the endometrium, and so it's going to be eccentric to the canal. And then basically you'll see this echogenic ring, which is basically the interface of the endometrial to the endometrial surfaces. So basically this is what we're looking for. So here's the endometrium, and you see there's this little echogenic line. This is the sign, and then here's the sac kind of located eccentrically within the endometrium. Another example here. So again, here eccentrically located, here's the echogenic thing, and here's actually the center of the endometrium. So this whole thing here is the endometrium, and here this is located eccentrically within it. Another example here. Again, here's the endometrial surface, and here's the sac, and here's the echogenic. See here's the endometrial, the surfaces basically abutting one another, and then, so again, that's called the intra-decidual sac sign. You're not going to be able to see that on a transab, but that's basically your earliest sign of an IUP on endovag. The double decidual sac sign, this has been described as the earliest transabdominal sign of an IUP. Basically, you get 2 echogenic rings seen within the endometrial cavity. And basically what it is the outer ring is the decidua parietalis, and it's basically the decidual lining of the uterine cavity. And then the decidua capsularis is the inner ring, and it basically covers the free margin of the gestational sac. And then the decidua basalis is the endometrial base of the sac itself. Decidua basalis plus the chorionic frangulosum actually will go on later to perform the placenta. A lot of gibberish, so a picture's worth 1,000 words, and so this is basically what's happening. So this is the gestational sac. Here's the endometrial cavity. Again, it's eccentrically located, and then this is the capsularis here. This is the parietalis, comes all the way around, and then the gestational sac forms. So this is actually where your placenta will form eventually. Some examples here. So again, here's the sac, eccentrically located, and here's our 2 echogenic lines here. So the double decidual sac sign. Another example here. This is an older picture, but again, here's the sac, here's the lines. It's a little bit older machines, is definitely a lot harder to see. So our machines today, a lot of this stuff is a lot easier to see than it was in the past. Another example here, here's the 2 lines, eccentrically located in the endometrium. All right, gestational sac size. Basically, you're measuring the mean sac diameter, and you want to measure the sonolucent area only, so make sure they're not actually including the echogenic chorionic rim. And it's basically length plus width plus depth, and you divide it by 3. Beta levels for visualizing the gestational sac, endovag, between, typically between 1 and 2,000, but again, you want to see it after, definitely if it's greater than 2,000, you should see it most of the time. Transabdominal is a little bit higher, usually around 3,600, you can see it transabdominally. Again, it increases in size about 1 millimeter a day. And then once the sac diameter reaches about 10 millimeters, you need to see a yolk sac. And then once the sac diameter reaches 25 millimeters, you need to see an embryo. And then basically the gestational sac is the chorionic sac. It's the same terminology. So what we don't want to do is confuse the gestational sac with a pseudogestational sac from an ectopic pregnancy. And so again, picture we just showed, this is with that double decidual sac sign versus just a little bit of fluid in the endometrial cavity. And so this is, the pseudogestational sac is going to be central. It's not going to be eccentrically located in the endometrium like the gestational sac will. So again, here just for comparison, here's that double decidual sac sign in a normal IUP, and then this is basically what a pseudogestational sac looks like. So this is pretty much the only thing I'm going to talk about for ectopic pregnancy. Is that. You just don't want to confuse them, so look for those signs. Just basically the pseudogestational sac is just a little thick decidual reaction surrounding the endometrial fluid. And unfortunately, we only see this in about 10% of patients with ectopic pregnancy that demonstrate this sign. So, just keep that in mind, look for those signs. Again, it's located centrally within the endometrial canal versus eccentrically for the normal gestational sac. Again, look for that double decidual sac sign. Any round or oval fluid collection in a woman with a positive pregnancy test most likely represents an intrauterine gestational sac and should be reported as such. It's much less likely to be a pseudogestational sac. Remember, it only happens in about 10% of ectopic pregnancies, which is not super common in the first place compared to normal early IUPs. A little bit about the membranes. Think of it as a small efficiency apartment with a kitchen and a bedroom. Basically, the kitchen is the chorion. It's basically where the food is, so that's where the blood supply is to the fetus. The chorion, the chorionic sac, and the gestational sac, it's all the same thing, so just there's different terms for it, but they all mean the same thing. So the yolk sac actually forms within the chorion, and basically remember that chorionic frondulosum plus that decidual basalis, that will actually go on to form the placenta. So this is basically the food supply for the fetus. The bedroom is the amnion. Basically, it's where the embryo forms. And so the embryo is attached to the chorion by a stalk, which will eventually develop into the umbilical cord. As the fetus develops, the amnion will expand. Eventually, the yolk sac detaches, and the membranes will fuse about 14 to 15 weeks, which is the end of the first trimester. All right, so some examples here. So here's our fetus. Here's our amnion. So basically, this is our amniotic membrane right here. Again, here you see it here. So here's the fetus, here's the amnion. Again, eventually this is going to expand out and it will actually fuse later. So here's a nice example here. So here's the amnion and here's the yolk sac. And again, remember this amnion is going to slowly expand over time and eventually it's going to fuse with the outer surface of the chorion. So development of the yolk sac. The presence of a yolk sac with a gestational sac, basically that confirms that there's an intrauterine pregnancy present. Again, we typically see it by 5 to 5.5 weeks after the patient's last menstrual period. It's going to be round and echogenic, and the amnion develops embryologically before the yolk sac, but the yolk sac is easier to see because it's got a thicker echogenic wall. And it should be visualized once your beta hits about 7,200, you should be able to see a yolk sac inside the gestational sac. Remember, the number of yolk sacs equals the number of amnions. And so this is important in multiple gestations. So basically you want to count the yolk sacs to determine the amnionicity. Remember that amniotic membrane can be very thin sometimes, so it can be very difficult to see. And so yolk sacs are a lot easier to see. And so you want to count the number of yolk sacs to give you, to determine your amniosity. Okay, so here's basically, it's kind of subtle here, but here's the yolk sac. Here's our gestational sac, our mean sac diameter. About 1.3, and so we're about 5 weeks along. And so sometimes they're real subtle, but this is actually the yolk sac here. This patient's beta was greater than 20,000. Yolk sac present. This was just an early IUP. This was actually a case from here, came in middle of the night one night, so it might happen, so at least you kind of know what to look for. So what's an abnormal yolk sac? Well, it indicates poor prognosis, and most of the time it's going to end in fetal demise. So if you don't see it, if it's too big, i.e. greater than about 6 millimeters, if it's irregular in shape, if it's got calcifications in it, or if you see multiple yolk sacs. And so here, this example here, this yolk sac was way too big. This one was about almost 11 millimeters. And so this did not go, this pregnancy terminated early. So the embryo, first seen as focal thickening on the yolk sac itself. There's something called the diamond ring sign. It's basically the embryo appears as an echinogenic diamond on top of the yolk sac. So think of the yolk sac as a backpack with a bunch of food in it for the embryo. The double bleb sign, basically the embryo is in the amniotic sac immediately adjacent to the yolk sac. Again, the embryo is going to grow inside the amnion, and then it grows by the yolk sac. Again, think of it as a backpack. That's the food supply for the baby is the yolk sac. A distinct embryo with cardiac activity should be seen by about 6 to 6.5 weeks. And embryo measurements, there's something called the crown rump length. That's basically you measure the fetus from the top of the head to the bottom of the butt. And that sort of gives you an estimate on how far along the baby is. It's a more accurate indicator of gestational age than the mean sac diameter. So you really only want to use mean sac diameter if you don't see an embryo. So here's the diamond ring sign. So again, here, this is actually the embryo, and here's the yolk sac right on its back. So it kind of looks like a diamond ring. Here's the double bleb sign. So here, this is going to be the yolk sac and the fetus, and then the embryons in between them. And so kind of similar there. Cardiac activity. A lot of times we can actually pick up cardiac activity before we actually can see the embryo. And it must be present if the embryo is greater than or equal to 7 millimeters in length for the crown rump length. At 5 to 6 weeks, typically the heart rate's between 1 and 110, and then 8 to 9 weeks it decreases to about 150 to 170. Bradycardia, bad. Do a follow-up scan. So if you get a decreased heart rate in a fetus, always do a follow-up scan. Babies do not like slow heart rates. So when you Doppler the placenta, basically you're getting mom's heart rate. Remember, there's all these connections, and basically that's how mom gets blood to the baby is through the placenta. And so the pulsations you're going to see there is basically you're looking at mom's heart rate, not the baby's heart rate. So here's an example here. This is called M-mode Doppler, and this, of course, is our typical spectral Doppler. Heart rate here was about 114 and 122 over here. There's just a couple different ways that you can do it, M-mode and duplex Doppler. You do want to be careful doing, if you can't, you want to really use M-mode. You don't actually, color Doppler is basically, it produces a lot of heat, and so you want to be very careful when you're doing color Doppler on babies. You don't want to spend a lot of time because it can generate heat. And so there's some theoretical risk there with causing damage, especially early on in pregnancy. So again, crown rump length of 7 millimeters, you should see fetal heart tones. And you want to document those in your report. Ramencephalon. This is a normal embryologic structure which eventually gives rise to the pons medulla cerebellum and the fourth ventricle. On ultrasound, it basically appears as a cystic structure located within the posterior aspect of the cranium, and we see it between weeks 8 and 11. And then basically this develops into a normally proportional fourth ventricle after the 11th week. And so again, you can see the importance of, accurate dating as far as, when the mom's last menstrual period was to determine, some of the stuff we're about to talk about. Dates are very important, and so you want that date to be as accurate as possible so you know if these structures that we're seeing are actually normal or something abnormal. Remember, again, during this time frame, this is a normal structure, so we don't want to confuse it with a hydrocephalus or a cystic brain mass. Here's a couple of examples here, and here's our yolk sac. Here's our ramencephalon, so basically this is the head, this is the butt. Another example here, another ramencephalon. Another example here, again, it almost always looks like this. It's going to be located posteriorly like that. Another example here, again, you can just catch a glimpse of that amnion. there. Here's the rhombencephalon. So here's the head, there's the butt. Physiologic gut herniation. This is another one of those where dates are very important. So at 8 to 10 weeks, there's physiologic herniation of the midgut as the GI tract is forming. This is visible as an echogenic mass at the base of the umbilical cord. By 12 weeks, the intestine has returned to its normal position in the abdominal cavity. So if you see this after 12 weeks, it's not normal. All right, so diagnosis of an omphalocele should not be made before 12 weeks or a crown lump length of about 45 millimeters or less unless the mass is greater than 7 millimeters or it contains liver or stomach. So again, physiologic bowel herniation. Here's an example here. Here's the umbilical cord going into, here's the echogenic lesion at the base of the umbilical cord. This is just, this fetus was 10 weeks, so this is just physiologic gut herniation. Here's another example from StatDX. Here's our yolk sac. So here's our head, and so here's actually, this is the physiologic gut herniation here as well. Again, timing is very important. For omphalocele, basically that's a midline abdominal wall defect with herniation of abdominal contents into the base of the umbilical cord. And again, remember, the timing of this is huge. So I mean, again, this is after 12 weeks is when you would make this diagnosis. So basically there'll be a smooth mass protruding from the central anterior abdominal wall. There'll actually be a covering membrane, which you can actually see sometimes. The umbilical cord inserts into the membrane itself, and then the most common contents are going to be liver and small bowel. There are associated structural abnormalities are common, cardiac, other GI abnormalities, aneuploidy, most commonly trisomy 18, Beckwith-Wiedemann, which is omphalocele, organomegaly, macroglossia. Again, all of these there are associations with omphalocele. So again, so basically you get the umbilical cord inserts on the membrane and basically herniated contents outside of the bowel wall, again, after 12 weeks. The example here, in this case here, so this is actually the baby. Here's the omphalocele. This would actually contain stomach and liver. And here's another example here. Here's the insertion of the umbilical cord here, and then it's kind of splitting out at the other vessels. And so here's the omphalocele. Again, this was during the second trimester here, and this was at 12 weeks. Gastroschisis is a little bit different. Basically, there's bowel herniation through a perimedian abdominal wall defect. And so it's not really, it's not really associated with the umbilical cord like the other two are. The umbilical cord inserts normally. There's no covering membrane. And small bowel always herniates through the defect. Occasionally, you'll see large bowel or stomach. There's a variable appearance of the bowel. It may be dilated. It may become thickened, echogenic, matted, nodular there's a fibrinous peel forms on the exposed bowel. But again, it's not covered with a membrane, so basically you just got bowel floating out in the gestational sac. If you see liver or other solid organs, gastroschisis is unlikely and considered a ruptured omphalocele or other entities such as amniotic bands, body stalk, or something called the pentology of Cantrell. And here's an example. So we have normal insertion of the umbilical cord, and here kind of right lateral to it you have basically small bowel, again, with no covering membrane. Here's some examples here. So here's the umbilical cord insertion, and then here's the gastroschisis. Another example here. Here's the umbilical cord inserting, and here's just the echogenic bowel loop. So this was another case of gastroschisis. All right, let's talk about twins a little bit. Multiple gestations. There's two types of twinning. There's dizygotic twinning, where there are two separate eggs are fertilized, and there's monozygotic twinning, where basically there's just one egg. So it's about 70-30% as far as how often that these happen. Remember, the number of chorions is your number of placentas. Sharing is bad, so you want the twins to have their own circulations. They don't like sharing. Just like my kids at home, my kids don't like sharing. So babies in the womb don't like sharing, and so when there's just one placenta, there's a high risk for twin-to-twin transfusion. So bad. Number of amnions equals the number of separate sacs. In this case, this is really bad. Sharing is really bad because there's actually risk for cord accidents. All right, so dizygotic twins, all are dichorionic. There's two placentas, and diamniotic, so there's always two sacs. So this is the easy one. So we call this dichorionic, diamniotic. Two placentas, two sacs, no sharing going on there, they're happy. All right, so basically what happens, you get 2 ova are fertilized, and each embryo develops in its own sac. So they each have their own little house to live in. Twins can be the same or different gender. Can also rarely occur after division of a single ovum within the first 3 days after fertilization. Doesn't happen very often, but it can happen that way as well. All right, so ultrasound findings for a di pregnancy. You got 2 fetuses and 2 separate chorionic sacs. If there's 2 separate gestational sacs are seen in the first trimester, basically this is diagnostic of a di pregnancy. So you do your first trimester, you see 2 separate sacs, you got your diagnosis there. Visualizing 2 placental sites or a thick inter-twin membrane, also correctly diagnosed. Di pregnancies in over 95% of the cases. High accuracy suggests the diagnosis should be made in the first trimester. There's something called the twin peak or the lambda sign. Basically, that's a triangular peak of villi extending from the placenta into the inter-twin membrane, and it's also indicative of a di twin gestation. So here's an example here. So we have two gestational sacs, thick membrane in between them. Again, 2 gestational sacs. This is that lambda sign. So this is what they call this the twin peak sign, and there's that membrane going between them. Another example here. Here's a really thick membrane between these 2 twins. Here's one placenta. Here's the other placenta. Again, 2 separate gestational sacs. All right. Monozygotic twins. All right. A third of these are going to be di. Basically, that's when they have that cleavage by 3 days, or by the 3rd day. 2/3 are going to be monochorionic diamniotic, and basically this is when cleavage occurs days 4 to 8. And very rarely there are monochorionic monoamniotic twins, and this is when cleavage occurs after 8 days. Conjoined twins occur when cleavage happens even later at greater than 14 days. And these are always going to be the same gender because, again, only one egg was fertilized, and so these are going to be either 2 boys or 2 girls. So mono-di ultrasound findings, basically you're going to have 2 fetuses in a single chorionic sac, but each is going to have their own amnion. Remember, the number of yolk sacs equals the number of amnions. But remember that yolk sac is a lot easier to see, especially early in pregnancy. Sorry. Didn't mean to. You're going to have a single placental mass as opposed to 2 placentas. And then you may actually see that thin inter-twin membrane. So here, so we have 1 gestational sac. Here's that thin dividing membrane, and there's only 1 placenta. Another example here, here's 2 yolk sacs. Here we don't actually see that thin amnion, but there are 2 amnions, we just can't see them because those membranes are so thin. Here, yolk sac, amnion, amnion. So here, each twin, they're together, but they each have their own sac. So that's good. All right, mono. All right, so this is basically there's 2 fetuses in a single sac. There's only 1 yolk sac. There's no inter-twin membrane. There's a single placental mass, just like there was in the mono-di. Majority of cases have cord entanglement. Again, remember they're sharing the same room, and that's not good. Bad things can happen, so cord entanglement is a big issue. 3D ultrasound is the most accurate imaging method in the early first trimester for this. Here's some examples here. Again, 1 gestational sac. We don't see a membrane, but we don't see the yolk sac. We don't really see the yolk sac either. So sometimes it's hard to tell, so you really want to look for those yolk sacs. Here, this is actually entanglement of the cords. This was also mono twins here. Conjoined twins. Basically, there's fusion to variable degree. There's all these funky terms here. Thoracopagus, basically they're fused at the chest. Omphalocele, they're fused from the xiphoid to the umbilicus. Pyopagus, fused at the butt. Ischiopagus, fused at the hips. These are always mono. So this is basically a variant of the mono twinning. And so these twins, conjoined twins, are always going to be mono. Fetuses are inseparable, again, because they're in complete separation. And you want to look for different heart rates. This was thoraco-omphalocele here, and so here, basically they're joined here. Really just, it looks like a garbled mess, but this is what this was. Another example here, and then this is a 3D ultrasound. You can see here they're fused at the chest. Thoraco-omphalocele. So why is all this important? So it's very important that we classify chorionicity and amnionicity. Perinatal death rate for Dizygotic twins versus mono twins, 75 to 1,000 versus 191. So more than twice the perinatal death rate in mono twins. Monochorionic twins share placental circulation and are at risk for twin transfusion syndrome and something called trap sequence. Basically, with trap sequence, one of the twins, basically there's reversal of perfusion. They call it the acardiac twin. And so one of the twins basically gets most of the blood flow and it shunts blood away from the twin, and basically the acardiac twin becomes malformed and it just basically doesn't make it. Chordal entanglement is also a big deal in mono twins as well. If you can imagine, if the umbilical cord gets tangled up, compromises blood flow, not a good deal. All right, so a little bit about some fetal complications during the first trimester. Non-viable intrauterine pregnancy. This is a new term that just started being used a few years back. Basically, it's the same new term for the anembryotic pregnancy or blighted ovum. It's sort of an older term you may see in some of the books, but it's basically a failed first trimester pregnancy. Again, those normal milestones are clear and must be met for normal pregnancy development. Again, that when you see that mean sac diameter is greater than or equal to 10 millimeters, you got to see the yolk sac. So look for the yolk sac. When the mean sac diameter hits 25 millimeters, you got to see the embryo. Failure to meet any of the above basically equals a failed pregnancy. All right, so here's an example here. It's a very large gestational sac. Nothing inside it. By this size here, you should see a fetal pole. There's no fetal pole. There's no yolk sac. It's just the same patient, different dimensions there. So mean sac diameter 2.4 centimeters, yolk sac. Maybe this is the yolk sac. This is from the literature. I guess that's a yolk sac there. But again, this is big enough. You should see an embryo because we're greater than 25 millimeters. There's no embryo in this gestational sac. Perigestational hemorrhage basically is a hematoma adjacent to the gestational sac in the first trimester. The source of the bleed is often the chorionic frangulosum, basically the early placenta. It's also called a subchorionic hematoma is another name for it. The best diagnostic clue is you get an intrauterine fluid collection that's separate from and adjacent to the gestational sac. Often it's going to be curvilinear. You may see the edge of the placenta lifted, and it can actually distort the gestational sac if it's big enough or in the right location. Again, blood appearance on ultrasound depends on how old it is. 90 to 95% of these have good outcome when a living embryo is present. And it can mimic a gestational sac or twin gestation. So you see this, that's sort of kind of in your differential. If you see what you think is two gestational sacs, one of them could potentially be, a perigestational hemorrhage. Clinical issues, 20% of these patients are going to present with vaginal bleeding. And then about 10 to 15% of them will actually go on to spontaneous abortion or just basically miscarriage. Basically, if we see perigestational hemorrhage and the gestational sac is less than 16 millimeters at the time of diagnosis, there's actually a pretty high risk of the pregnancy actually going on to fail. So here's an example here. So this is the hematoma here adjacent to the. Actually, it's this. So this echogenic part here. This was actually the hemorrhage. Another example here. So here's our sac. Here's the perigestational hemorrhage. And this is an even larger one. So here's the sac. Here's our yolk sac, and here's this very large hemorrhage here. Another example here. So basically, it's a separate fluid collection from the gestational sac. So this was a blighted ovum. All right, so a little bit about first trimester splitting for aneuploidy. There's something called nuchal thickness that we look at. This is where us as radiologists, we got to kind of choose our battles wisely. This is one of those things that I would probably leave this to the OBs because you don't want to screw this up. So, it's like there's all this stuff about turf battles. And so they're doing this in most places, but I want you to be aware of it just in case you see something like that and you'll kind of know exactly kind of what they're talking about. But yeah, this is one of those things you don't want to mess this up when they're doing these measurements. So basically there's a nuchal translucent, there's a thin layer of fluid seen in the posterior neck region during the first trimester. And then so when you do this, again, the timing is important. So we do the measurements are performed between 11 and 14 weeks. Most fetuses with trisomy 21, as well as some of the other ones, and even some normal fetuses actually have an increased nuchal thickness of greater than 95th percentile for the menstrual age. And nuchal thickness allows identification of about 3/4 of fetuses with trisomy 21 and about 70% of fetuses with other chromosomal abnormalities such as trisomy 13, 18, and Turner syndrome. So basically, a nuchal thickness of greater than or equal to 3 millimeters is always abnormal. But to learn how to do this, though, it takes time and patience. There's actually specific guidelines by the AIUM for correct measurements. Correct caliper placement is critical. So as you can see, you don't want to accidentally say, oh, I think your kid may have Downs, and then they actually don't. So this is, you can see, I mean, there's other tests and stuff that people will get done, blood tests and stuff like this. But again, this is one of those things that if you're not comfortable doing it, I would leave it alone. But I just wanted y'all to be aware of it in the talk. So. Increased nuchal thickness can also be seen with congenital heart disease and with certain syndromes. So here's an example here. So this is basically this is the area they're measuring. You'd see there's this real thin little kind of there's a little bit of fluid here, or fluid exogenicity. So this is actually what they're measuring. So this is normal. It's about 1.5 millimeters, and this one is. Here, the significant lamina, this baby actually had Downs. This was also at 12 weeks. You see significantly thicker here compared with the normal. And this was just a one that didn't make it. Again, this is the anatomic correlate to what we're seeing here. So this patient, this kid actually had gastroschisis, also had increased nuchal thickness along with the gastroschisis. Also had some skeletal dysplasias. Nasal bone ossification. Nasal bone ossification should be seen at 11 to 14 weeks. You first see it with a crown rump length of around 42 millimeters. Normal skin, there's actually 3 distinct lines. There's the skin over the nasal bone, there's the echogenic nasal bone that runs parallel to the skin, and then you also see the tip of the nose. Absence of nasal bone is associated with increased risk of trisomy 21. As the nuchal thickness increases, the incidence of the absent nasal bone increases. So these two things kind of go together. Again, just as with nuchal thickness, ultrasound technique is very important. I mean, you got to be right where where the nasal bone is to actually be able to even see this. So technique is very important. So this is basically what we're looking at. So here's the normal nasal bone ossification center. Here's the skin surface, and here's the tip of the nose. So there's our 3 lines right there. Tip of nose, skin over the nasal bone. There's our 3 dots. And then here, this was a trisomy 21. There's basically, here's the tip of the nose and the skin, but that ossification of the nasal bone was absent. And again, here's the we don't have a measurement, but the nuchal thickness was also increased. So pitfalls, there's some stuff you guys to be aware of. Again, mistaking the yolk sac for the embryo, kind of be careful. The embryo should form along the yolk sac. We don't want to mistake subchorionic hemorrhages for a twin gestation. We don't want to miss multiple gestational sacs. We don't want to, look out for that. Even though, remember, you only see that pseudo-sac of ectopic pregnancy in about 10% of ectopic cases. And again, it's that fluid collection centrally within the endometrial canal as opposed to eccentrically as the normal gestational sac should be. Normal rhombencephalon, don't confuse that for cystic brain mass. Physiologic bowel herniation for omphalocele. You don't want to mistake those things. Remember, timing is very important in that. Take-home points, important beta levels, greater than 2,000, you should almost always see a gestational sac. Remember, there's that small percentage of pregnancies you may not. Just get a follow-up in a couple of days. Remember that beta should keep going up. Everything is sort of kind of planned out, and so, nobody's going to fault you for getting, if you're not sure, just get a short-term follow-up. 7,200, we should see a yolk sac. At 10,800, we should see a fetal pole. Remember, crown rump length of 7 millimeters, you should see fetal heart tones. Mean sac diameter of 10 millimeters, you should see a yolk sac. Mean sac diameter of 25 millimeters, you should see a fetal pole. All right, so here's our pop quiz answers. All right, so normal or abnormal, Carson?
Normal.
What is that?
Yolk sac and yolk sac.
Good. Tom, what structure is the white arrow pointing to? That's the amnion. Good. And what is the black arrow pointing to?
The rhombencephalon.
Good. Sana, what are the chorionicity, amnionicity of these twins?
So it looks like there's the twin peak, so it's dichorionic, and then you should be assuming it would be diamniotic as well.
Good. This is a dichorionic, diamnionic twin. And what sonographic sign is it? You already said it.
Twin peak lambda.
There, good. All right, last case. Robbie. So what's the diagnosis? Patient, the kid's 13 weeks.
Is that ever pointing to the umbilical cord?
Yeah, that's the second. So you got that. What's the diagnosis here? Yes, the umbilical cord. This is a good article, Diagnostic Criteria for Non-Viable Pregnancy Early in the First Trimester. Just if you want to have something on your iPad or whatever, this is a pretty good article to have. It's a review article from the New England Journal of Medicine. Questions? I know it's a lot, but I wanted to try to kind of summarize a lot. There's a lot of stuff, but I mean, this is kind of the high points. This is kind of the stuff that you may be asked on call, or you may potentially. I don't know how much this shows up on the core exam, but this was fair game back in the day on the oral stuff. So, all right, thanks, guys.